I think I should turn to introduce the next speaker.
Please. Thank you very much, Dr. Cohen. Thank you very much, Dr. Miller. Please, Dr. Miller, to introduce the next speaker. Thank you.
So our next speaker, I constructed this morning with Naren's collaboration to go from this overview of the molecular landscape of the pathology classification to some basic neurobiology, basic molecular biology. And then we'll talk a little bit about, Dr. Odapi will talk a little bit about methylation array classifiers, which is a relatively new thing. And then get to specific entities. Dr. Hawkins talking about gliomas, Dr. Fillings and Dr. Samuel about ependymomas, and Naren will finish up talking about medulloblastomas and perhaps a word about some of the other embryonal tumors. So our next speaker is Dr. Pratiti, and I'm going to mess this up, so I'm sorry, Bandopadhayay. She is a pediatric neuro-oncologist at Boston Children's and the Dana-Farber Cancer Institute and Boston Children's Cancer and Blood Disorders Center. She's currently assistant professor of pediatrics at the Harvard Medical School, earned her MBBS at Monash University Medical School in Melbourne in Australia, did a pediatric residency in hematology oncology at the Royal Children's Hospital in Melbourne. She then came to the United States, did a fellowship in pediatric neuro-oncology at Dana-Farber and Boston Children's, and that finished up, I think, in 2013. She's an associate member of the Broad Institute of MIT and Harvard as well, and has an active laboratory in addition to being a working pediatric neuro-oncologist. And I will mute myself and turn it over to you.
Thanks, Dr. Miller, and thank you to everyone for the very kind invitation to present. I'm really excited to virtually be here. As Dr. Miller said, I'm a pediatric neuro-oncologist. I'm Australian, but I've been in Boston for just over 10 years now. And I have the privilege of leading a lab that applies genomic approaches to study childhood brain tumors. And what I thought I'll do today is just give an overview of how I think some of these genomic findings, the new classifications that Dr. Miller presented, is starting to impact the clinical care of children. And some of the challenges that we face, as Dr. Cohen said, worldwide actually, to how do you integrate this when you have a child sitting in front of you in the clinic, and some of the advances and some of the challenges. So before I go into this is just my disclosure slide. My lab receives grant funding from Novartis for unrelated work and has received funding from Deerfield and QED Therapeutics. So this is very well known to this group, but I always start talks like this with this because to me it is why we're all here. More children are diagnosed with brain tumors than any other solid tumor. And even though there's been tremendous advances in some of the other diseases, we have not seen the same translation of improved survival in children with brain tumors. So more children die now of brain tumors than any other cancer. And the other thing that I think is often overlooked when we talk about survivals is that those kids that survive are absolutely devastated very frequently, right? So we talk about 70 or 80% cure rates of medulloblastoma, but that's at a huge cost with high-dose craniospinal radiation, chemotherapy, and then all the subsequent sequelae, including second malignancies. And when I sort of was training, so this will age me, the year I graduated, actually, I graduated in 2001. The human sequence, the sequence of the human genome was published for the first time. And as you saw in Dr. Miller's talk, that has really changed our understanding of the last 2 decades of the biology. We now know that these tumors are not the same as adult cancers at all, and treating childhood brain tumors the same way as we treat adult brain tumors is really not sufficient. And the biggest challenge that I sort of see at the moment is I feel that the science is proceeding very rapidly. And every day we're learning more and more things about what causes a childhood brain tumor to form. But a real challenge that we have in oncology is actually how do we translate these findings into the clinical care for our child, right? We can subtype medulloblastomas with really high resolution, and you've seen that, and I'll show you that as well. But how do we actually make that a change into the clinical care of the children And how do we then hopefully use that to improve survival? And for me, I always sort of think about it, well, the dream that we all have is that when we meet a patient in clinic, we'll be able to say, little Jessica or little Joey has this brain tumor, and we'll be able to tell the mum or dad or the family that their little child has a tumor. We'll be able to give them exactly the drivers of the tumor, and then be able to say, here's a therapeutic approach that will target your child's tumor, and we'll be able to give them a high chance of cure with low toxicity, right? That's what we all are aiming for. But for that to happen, many things need to come into place, right? There are many pieces of a puzzle that I think need to all come into place for us to be able to effectively offer precision medicine approaches for every child in clinic. And so these are very basically some of the things that I think about and what we think about in the lab. We need to learn about, so we need to identify the mutations and the genetic drivers. And I think as a group, the field has come a very long way in trying to understand the biology. But we need to understand what each of these alterations actually do in very deep biology to actually cause the tumors, right? Because if you don't understand what all of these alterations are doing in causing a tumor to form, then how are we ever going to reverse that? So there has to be really deep biology. We need drugs that will be specifically able to target those alterations. And in neuro-oncology, the bar is even higher because not only do we need drugs, we need those drugs to be able to penetrate through the blood-brain barrier with high enough concentration to get into the brain to have an effect. And then assuming we have a good understanding of the biology and we have drugs to target them, we know that tumors are not just a stagnant population of cells. They are heterogeneous tumors with genetic heterogeneity, transcriptional heterogeneity, and the selective pressures placed by treatments, the bottleneck placed by treatments, makes the tumors evolve so that they become resistant. And so we need to preemptively actually understand the resistance mechanisms of all of these new inhibitors rather than waiting to go into clinic and then knowing that the kids are going to become resistant. So this is, to me, a big part of the puzzle. We need to have assays that will accurately diagnose these tumors, and as Dr. Cohen said, in a rapid turnaround time so that they're actually clinically relevant. And then once we all have all of this, we also need effective ways to monitor response. Right now, we heavily base our monitoring on MRIs, but are there other ways to actually track response to these therapies? So it's actually a really high bar to be able to successfully have precision medicine approaches for kids with brain tumors. It's what we're all hoping to get to, but I think we have a really long way to go. But we are learning a lot, and I think, even in the span of my career, which is it is still evolving, the way, as I said, we've been thinking about tumors has completely changed. So one of the big things for me is this realization that pediatric tumors are not the same as adult cancers at all. So here I'm showing a plot that on the x-axis has different human cancers, and on the y-axis has somatic mutation rates. And one of the big lessons that we have found in pediatric cancers, not just brain tumors, but including brain tumors, is that by and large, childhood cancers are much simpler in a genetic sense compared to adult cancers. So on the list of tumors, I've highlighted the pediatric cancers, and you can see on the right, the tumors that have the highest mutational frequencies are adult cancers, such as melanomas that are associated with environmental exposures, right? So UV light causes mutations that increase the rate of transformation, and so melanomas have high mutation rates. But childhood cancers have really low somatic mutation rates, and some of them, for example, rhabdoid tumors or low-grade gliomas, which I'll show you, and I know Dr. Hawkins will show you later, actually defined by single driver alterations. Now, this is a very unique thing for childhood cancers, because it makes you think that there's something that has gone wrong in development where a single alteration is sufficient to turn on a pathway that is important in development and be sufficient to actually induce tumor formation. So this is another way to look at it. Here I'm showing you copy number profiles of 3 ovarian cancers. So each column here represents a tumor, and I'm showing the different chromosomes. Where you see red, it's an amplification or a gain. So more than the 2 copies of DNA for each of those locations. And where you see a blue, it's a deletion. And when you look at these 3 tumors, you can see there's a lot of red and blue. There's a lot of aneuploidy, a lot of genetic disruption. And it's actually very hard to look at this and say the driver of this tumor is this gene on whatever chromosome, right? These are just very disrupted tumors. When we look at 3 pediatric low-grade gliomas as a contrast, so here are 3 diffuse astrocytomas that harbor MIVAL1 rearrangements, you can see there's a lot of white, right? So these are very genetically stable tumors. And you can see there's one region where there's an amplification or a structural variant that is sufficient to cause this tumor. So this has some implications when we think about childhood tumors. One is that it has implications for diagnostic studies. So if this child comes to me in clinic and has one single driver alteration, and the diagnostic panels that we use are, for example, designed for adult tumors or don't encompass all of the driver alterations that we see, the likelihood is that we'll miss this driver because it's just this one single event, right? So when we think about diagnostic platforms, they need to be designed specifically for childhood tumors, keeping this in mind. But the other thing is that it actually gives us a lot of therapeutic optimism, because if there's just one driver turning a tumor on, then if we can effectively target that driver, then perhaps we can actually make the tumors respond quicker, right? So an ovarian tumor, if I go in with the drug to target chromosome 7, for example, there's many other alterations that are contributing to that tumor's growth. Whereas in pediatric brain tumors, many of them, particularly the low grades, are characterized by single driver events. As you heard from Dr. Miller, we know that even though histologically the tumors might be called the same entity, that molecularly there are many different subtypes. And this knowledge has evolved over the last decade, starting with some of these early papers in medulloblastoma based on gene expression profiling that showed that there are many different subtypes of medulloblastoma within this overarching group of tumors. And the same patterns are seen across all of the different tumors, where pediatric low-grade gliomas have multiple genetic drivers, high-grade gliomas have multiple genetic drivers, and so there's complexities within each tumor type. We are in the lab across the world working collaboratively to try and develop strategies to target each of these drivers. This really is based on a deep understanding of the profiles of the tumors, the biology that is associated with the genetic drivers, and then understanding vulnerabilities either through genetic assays such as CRISPR screens, compound screens, and really deep cancer biology to try and understand each of these drivers so that we can hopefully have therapeutic approaches to target them. So when I sort of think about what is the role of molecular characterization or profiling, there are multiple roles, but the really 2 practical things are to aid diagnosis, as Dr. Miller has shown you, and then to see if we can use that to inform therapeutic approaches for the kids. So there are many different ways that you can molecularly profile a brain tumor. At Dana-Farber and Boston Children's, we use a hybrid approach, as do many other centers. And I think this is one of the messages that I want to sort of pass on, is that I don't think that there's one specific genetic panel or profiling method that really gives you the answers all the time. So in our program, and I said in others, we have 2 DNA-based assays. One on the left is looking for copy number. So it's an array-based assay, which looks for copy number alterations across the genome. But as I just showed you, often pediatric brain tumors have very few copy number alterations. They can have mutations, and they often have mutations in the intron. So we complement the copy number-based assay with a hybrid capture-based sequencing panel, which is called OncoPanel, that is constantly changing, but it basically encompasses about 500 genes that are most commonly mutated in cancer, including all of the exons and the introns that are most commonly associated with cancer. We also frequently perform a RNA-based fusion panel. And then as we've looked to see the ability of these panels to actually be clinically relevant, when we look at the different subtypes, we find that they are actually, if you combined copy number and mutation and a fusion panel, it is sufficient to subtype or detect the alterations in the majority of pediatric brain tumors. I have a couple of sort of points there. The fusion panel and the clinical sequencing panel needs to be designed specifically for pediatric brain tumors. Applying a panel that is designed for adult cancers without taking into consideration the alterations that are most commonly found in brain tumors will miss the alterations that we find in brain tumors. And then as Dr. Miller has shown you, and you'll hear from Dr. Aldapi, the ability to also subtype or cluster tumors based on their methylation and copy number profiles, comparing it to a reference classifier of thousands of of methylation profiles of cancers, has added an additional ability to classify brain tumors based on this. But all of these assays have pros and cons. The methylation profiling is very effective in clustering and telling you that this tumor most closely represents or resembles, for example, a low-grade glioma or a high-grade glioma, but it doesn't give you the mutation cause that you might need to actually be able to say that this child has a mutation that will respond to this drug. So our approach is to complement methylation profiling with a mutational-based profiler like the hybrid capture, and then copy number you can get from methylation or from an array-based copy number profile. So that's a little bit confusing, and I think, as Dr. Cohen pointed out, this is really evolving across centers as to the best way to do this in a clear, certified, efficient way. But I think we also need to understand that there are nuances for each of these, and not one method is 100% effective in classifying every single tumor. And I think we all need to recognize that. You've heard about the version 5 of the WHO, which basically I've just put up. I'm not going to go through this other than to say that it really has increased our understanding of the heterogeneity of each of these subtypes, right? So gliomas are not just low-grade or high-grade. Gliomas encompass many different disease types. Each tumor is a rare tumor in its own right. Similarly, low-grade gliomas are also heterogeneous, right? We've known that they're pathologically heterogeneous for many years, but we also know that they're now genetically heterogeneous. And I'm going to go into low-grade gliomas a little bit more as a primer for Dr. Hawkins' talk a little bit later. Similarly, high-grade gliomas, right? They're not the same as adult IDHs in the majority. They're defined by different histone mutations, and each of these are starting to have different prognostic and therapeutic implications. And similarly with ependymomas and medulloblastomas. But, you know, we are increasingly subtyping and recognizing the subtypes of tumors, and that has implications for how do we treat the kids, how do we design clinical trials, because now we're making a group of rare tumors into a group of very rare tumors. But clinically, we also need to remember that even though that there might be different subtypes, these subtypes can often share things, challenges, treatment approaches that are relevant for multiple subtypes. So I've just put this slide up as an example of infant brain tumors, right? Each of these are rare in their own right, but unfortunately we see them frequently enough in our clinics. They have babies have unique challenges in terms of surgery, location of the tumors, the ability to access trials, the ability for children to be able to swallow the drugs, resistance. And so here, understanding the subtypes is important, but also recognizing that sometimes these treatment approaches and the way we think about it is actually, we have to think about the challenges that are common across some of these different tumor types. I've also, at the start I said we need methods to be able to track response of tumors, and, we all use MRIs. The last 5 years or so, there's been a lot of excitement about the role of liquid biopsies, particularly in non-brain tumors, right? Adult cancers or children with extracranial tumors. And there has definitely been a lot of work across groups to try and understand how relevant liquid biopsies might be for kids with brain tumors. And there's been a few studies that have looked in blood or CSF to try and track, for example, histone mutations, because wouldn't it be wonderful if we could actually diagnose a brain tumor without the need for a craniotomy or be able to actually track this. But brain tumors have extra challenges compared to extracranial tumors. They have a blood-brain barrier that changes the amount of circulating DNA or DNA from the tumors in the blood. And children have extra challenges where it is hard to sample large amounts of blood for liquid biopsies. And so we've been interested in trying to actually understand how reliable these assays could actually be for children. And in particular, we've been interested in actually really defining what is the sensitivity. So if you take 100 kids with brain tumors, how often will we actually be able to robustly detect cell-free DNA? And then how reliable is it? What is the specificity? And so our first attempt to try and understand this, we actually took an approach and said, we're going to try and collect samples from every child that comes into our clinic prospectively. And we designed 2 genetic platforms to try and detect cell-free DNA. So this was in collaboration with Victor Adelstein, who leads the blood biopsy team at the Broad Institute. And basically, we collected samples from plasma, CSF, if kids had lumbar punctures, and urine, and then designed a pediatric brain tumor-specific hybrid capture panel to detect mutations and fusions, and also applied ultra-low-pass whole genome sequencing, and to see if we could first detect copy number or mutation profiles that are suggestive of cell-free DNA, and then compare it back to the matched primary tumor to actually see how reliable these profiles were. And so in this study, we actually ended up collecting samples from more than 250 children, predominantly blood and urine, and a smaller number of CSF. And we included all histological subtypes. The breakdown of the tumors in this cohort match what we see in clinic, where low-grade gliomas are the most common, followed by medulloblastomas and high-grade gliomas, and then some of the other rarer subtypes. And the first thing that we did was collect the blood and the urine and the CSF, and we performed ultra-low-pass whole sequencing, so 10x sequencing of the whole genome in the cell-free DNA extracted from these samples. And we looked at the normal matching tumors and looked to see whether the copy number profiles of what we were detecting in the cell-free DNA matched what we were detecting in the tumors. And the result was eye-opening and disappointing, where we took 260, and the majority of the copy number profiles that were being detected by the ultra-low pass did not actually correlate with the tumors, and only 13 samples from 10 tumors actually had copy number profiles. So this was sort of a first sign of, even though we're excited about the ability to be able to use liquid biopsies, ultra-low pass whole genome sequencing of cell-free is not sufficient. And the reason for this is what I alluded to at the start, is if you look at the copy number profiles of the kids who are coming through clinic and that we're collecting cell-free DNA on, the majority of children have tumors with very small amounts of aneuploidy and have very balanced genomes. So here we're showing a heat map. All the tumors represent all the columns represent a single tumor. We've got the different chromosomes. Red is the amplification, blue is the deletion, right? So you can see there's a group of tumors here on the left that have aneuploidy. And of these, we detected copy number profiles that matched in a subset, so 13 out of 78. The rest of these didn't even have copy number profiles that would ever be able to detect by cell-free DNA. So that's the first sort of lesson from this was, even though this approach is really exciting and successful in things like breast cancer, solid tumors that are extracranial, it's not sufficient for kids with brain tumors. So then we said, well, okay, if we can't detect copy numbers, can we detect the driver alterations? And so here we designed a panel which had 46 of the genes that were most commonly mutated or altered in childhood brain tumors. And we had benchmarked this panel to be able to actually detect tumors, cell-free DNA with at least 80% sensitivity with a tumor fraction of 0.01% with very deep sequencing, so 10,000 X coverage. And we applied this to a subset of the tumors. And similarly, the results are actually really disappointing. So when we first looked at the results, you get your sequencing reads, and we said, here's a child with a low-grade glioma. Can we see the V600E mutation? And so yellow, 2 tumors here where we saw V600E mutations where the tumor had V600Es. So that was kind of exciting. But then we said, well, wait, what is the actual accuracy of this, right? What is the specificity? So we then went and looked at a bunch of other tumors that we knew did not have the V600E mutation and said, can we actually see the mutation in the reads? And sure enough, you could see them, right? So what we found is that if you sequence tumors, if you sequence cell-free DNA from tumors and go in and say, in the reads that come out, can we detect whatever mutation we want? There is a really high rate of false positives because of sequencing artifacts. And if you don't look for that, which a lot of people don't, if you're not aware of this, you might actually say, hey, I can detect the V600E mutation, but you're not actually tracking anything other than noise. We did that across a number of other mutations. So there's been a lot of excitement, for example, in detecting the K27M histone mutation, or IDH. And similarly, with just looking at the reads and seeing what the mutations are there are really high rates of false positives. And this for us was, from a clinical point of view, really disappointing, but from a scientific point of view, really important to actually say, people, we need to be careful about this, because right now these assays as they stand, if you use these sorts of approaches, are not sufficient to meet a clinical metric. So we tried to then apply algorithms which would try to reduce the rates of false positives. And one of the ways that we did that was to actually apply a unique molecular identifier pipeline so that you can actually track the sequencing reads to which DNA molecule they came from. And when we use these more stringent approaches, out of the 86 samples that we had applied to this deep sequencing, we were only able to detect cell-free DNA reliably and robustly in 4 of the patients. And all 4 of these were from high-grade gliomas. And so this was a study that I think is important in showing us that we still have a long way to go in trying to be able to apply liquid biopsy approaches for kids with brain tumors. We think there are a number of reasons why it's harder to do this than it is in some of the other extracranial tumors. One is, as I said, in childhood brain tumors and other childhood cancers, there are fewer numbers of somatic alterations to detect. There could be technical reasons, and I'll show you that it wasn't because of our coverage. But we think that the rates of circulating tumor DNA is low to start with. And then in a small child, we're limited by amounts of sample that we can actually obtain. So first question was, of the tumors that we profiled, how frequently did they actually have an alteration that we would have detected with that panel? So even though we prospectively designed the panel and said this should detect the alterations in the majority. In real life, when we applied the panel to kids coming into clinic without selecting out anything, the majority of children actually only had one or less alterations, right? So we weren't even able to detect the alterations in the majority of children. We were able to go in and look to see what our coverage was. So of the tumors that had callable alterations, when we actually looked at the number of reads that we're getting more than 1,000x coverage. So that was above our sensitivity. So we were able to achieve enough coverage. But this was the big reason that we think it's really challenging, is that we know that at 1% cell-free DNA concentration or circulating tumor DNA, our assay has 90% power to detect alterations in 80%. But we only detected alterations in 4%, right? So 4% of our reads, so 1% is this blue line. Our panel was powered, or is sufficient to actually detect alterations more than that, but we only detected samples in one of these. So our conclusion here is that the main reason why we're not detecting cell-free DNA in these kids is that even though the panel is able to detect low concentrations, the samples themselves that we're obtaining from the kids do not have enough cell-free DNA to actually detect it. So I just wanted to put that out there because there's been a lot of excitement, and I think we need caution and we need more methods and technologies to really increase our ability to detect cell-free DNA. I just want to bring it back to how is all of this actually playing into our clinic and when we're seeing children who are coming to us with brain tumors. So I'm going to use low-grade gliomas as an example of the advantages and the benefits. And the reason for this is that I think that over the last 10 years, low-grade gliomas has become a poster child for targeted medicine and precision medicine approaches for pediatric cancers in general, but especially brain tumors. I always talk about low-grade gliomas in kids and make this point that pediatric low-grade gliomas are very, very different to adult low-grade gliomas. They have very different drivers, but they also have a very distinct clinical course that we need to keep in mind as we start using these new inhibitors. So unlike an adult patient with an IDH mutant low-grade gliomas, the rate of transformation of pediatric low-grade gliomas to a higher grade tumor is very low. So this was a study that we did approaching 10 years ago now, where we looked at the SEER database. So the SEER database is an American, a US database, cancer registry, where you can track diagnoses, but also some limited treatments, whether they had full surgical resections, subtotal resections, and then outcomes. And what we found is that when we tracked 4,000 children who were diagnosed over the decades before, the majority of kids are still alive as young adults, whereas an adult chart, they progress and die within 10, 15 years. We've also learned that these tumors are genetically heterogeneous. This is a commute plot of the genetic alterations found in pediatric low-grade glioma. So again, every column represents a tumor. And the genes here that we're showing you on the left are the genes that are most commonly alterated. Here, this was a cohort of about 150 children that we profiled with whole genome sequencing. There are a couple of messages that I want to want you guys to take from this commute plot. First is that I've color-coded the alteration. So where you see orange, it's a structural variant. Where you see blue, it's a point mutation. So low-grade gliomas, by and large, are a disease of structural variants and fusions versus point mutations. And the most commonly altered gene is BRef, as you know and as you've heard. But then you also see mutations in other genes was commonly converging on the MAPK pathway, for example, FGFR, and we're starting to find more and more FGFR alterations as we biopsy more of the midline gliomas. And then a subset of gliomas, as you also heard, have MIB alterations. The other message, which I will keep going back to, is that you'll see that there's a lot of white, right? So these are single driver alterations. But we were, as a community, lucky in that the most common alterations for kids with low-grade gliomas converged on the MAPK and mTOR signaling pathways. And the reason I say we were lucky is that the same pathway, as you know, is mutated in melanoma. And before the discovery of these alterations were made in low-grade gliomas, our adult colleagues working with pharma had already developed and tried a number of drugs that targeted this pathway, including BRef and MEK inhibitors. So one of the biggest challenges that we have for targeted therapies of precision medicine is actually having drugs that work and having drugs that we can use in children. And we were able to leverage what our adult colleagues had learned in melanoma for kids with low-grade gliomas. And this has allowed a number of different trials to actually target these acts, the MAPK or the mTOR, and we've had a number of clinical trials now studying the efficacy. So there are type 1 and type 2 inhibitors that can directly inhibit BRef. There are MEK inhibitors that will target the pathway downstream of BRef. And then there are drugs such as everolimus that can target, for example, the mTOR pathway. And all of these drugs have gone through varying stages and are going through various stages of clinical trials for children with low-grade gliomas. I put this slide up because I think it's really important for people that do not think of genomics frequently to understand that a BRef mutation is not the same as a BRef rearrangement. We often use different words to describe a BRef rearrangement. You'll hear them talk about a tandem duplication. You'll hear us talk about Kaya 1549 BRef. You'll hear the words BRef fusions. This is really important because there are major therapeutic implications if we don't understand the differences. So the BRef V600E mutation is a point mutation that results in constitutive activation of the BRef kinase. In the BRef rearrangements, we have a juxtaposition of another gene. Most commonly, it's Kaya 1549, but there can be multiple partners. And this juxtaposition results in activation of BRef by loss of the negative regulatory domain. Okay? But this fusion can still dimerize, and you still have a wild type allele of the BRef that can also dimerize and function. So as these mutations were discovered, the two different BRef inhibitors have gone through trials. The type 1 BRef inhibitors that were developed for melanoma that target the V600E mutation have been really exciting and have shown a lot of efficacy in children with that BRef mutated or that V600E mutant low grade. So here's an example of a patient that we treated, had a large tumor here, had a debulking biopsy. We don't want to, result in neurological deficit. So the surgeon appropriately left residual here, and we treated this child with a type 1 BRef inhibitor and saw really unprecedented responses. It's very uncommon for us to see such degrees of responses with vincristine carbo or some of the traditional chemotherapies. So this has been really exciting. However, if you use that same drug in a child with a BRef rearranged glioma, then we can actually cause some harm. So this is preclinical work that shows that if you have cells that have the V600E mutation or the BRef rearrangement, and you treat these cells with a BRef inhibitor, you can see here on this Western blot, I'm showing activation ERK, which is one of the substrates of the MAPK pathway. And you can see that the type 1 BRef inhibitor really effectively shuts down this pathway. And that's why we're seeing the responses. However, in children with the BRef rearrangements, if you use these type 1 BRef inhibitors, not only do you not get the same level of suppression, with prolonged dosing and high dosing, you actually get increased activation of the pathway. You get a paradoxical activation and growth of BRef rearranged gliomas with a type 1 BRef inhibitor. And that is because you still have a wild type BRef allele there. It's still able to dimerize and result in paradoxical activation is what we think. So I think this is really important for people when you start getting the genetic results back to understand the differences between the mutation and the rearrangement, and the fact that type 1 BRef inhibitors are contradicted. The good news is that there are other ways to target this pathway for children with the BRef duplicated low-grade gliomas, and MEK inhibitors have got through phase 1 and phase 2 and are now being evaluated in phase 3 studies for these children. And the results have been pretty exciting. And again, very different in terms of responses to what we commonly see with traditional chemo. So selumetinib is one of the MEK inhibitors. This waterfall plot I'm showing you is from the Paediatric Brain Tumor Consortium study led by Jason Fangasaro, where in a phase 1 and phase 2, they treated a cohort of kids with low-grade gliomas. Here you can see a number of children actually had reductions in their tumors, including BRef fusions or rearranged in blue and mutated. There are some challenges. As you can see, there are 4 children here where the tumors didn't respond, and we need to understand why. There are a new group of BRef inhibitors. You'll hear them described as type 2 BRef inhibitors that are now being evaluated as a way to stabilize BRef for the kids with rearrangements. That drug or those drugs are going through early phase clinical studies. But right now, if you have a BRef rearranged tumor, the most tested way to target it is through the use of a MEK inhibitor. But there are major challenges, I think, emerging that we are behind in the lab in trying to understand. And I think this actually has pretty major implications in that in the children's oncology group right now, we have 2 phase 3 studies, which include MEK inhibitors, one for children at diagnosis and one for children at relapse. And what we are starting to find, not in that study, but just in kids that have been treated, is that we see impressive responses in a lot of children. So this is a child this was actually a V600E ganglioglioma that we treated with a type 1 BRef inhibitor here, got a pretty impressive response with 12 months of treatment. But when we stopped the drug within a month, the tumor has grown back. And we're starting to see this pattern of regrowth or rebound when we stop the inhibitors for both BRef and MEK inhibitors in more than 50% of children. We're still trying to work out what the real numbers are because this is happening in real terms. But now we have had kids who have been on these inhibitors for 4 or 5 years continuously versus what we would have done in the past, which would have been 12 months of incretin and carboplatin. And for me, I think biologically, what I'm concerned about is we do not have any understanding of the long-term implications and side effects of the use of these drugs for children. We're going to learn that in the next 10 years. And we don't know if this is going to play in with that natural history of stabilization of low-grade gliomas. And so this is something that we need to understand. And then, as I said, we still don't have a good understanding of why some children don't respond to these to these drugs. So this is just my last slide, and we can have a little bit of time for discussion. But as you heard in Dr. Miller's talk and as we're seeing in the lab, I'm really excited by the biology that we have learned and are continuing to learn over the last 10, 20 years. I feel like we are living in the era that our leukemia colleagues did in the 70s and 80s when they took an incurable disease and were able to cure leukemia. I feel that we're living that right now for children with brain tumors, and it's really exciting to think where we're going to be in another 10 years. But we also need to be, I think, cognizant that we don't know what we don't know, and we have no idea about how best to use these drugs, how to overcome resistance, and to be really cognizant of the fact that we are going to learn about the long-term effects of these drugs as they come, right? We need to understand the biology. I think the BRef story is a big one in terms of if you don't understand the biology and just try and use an inhibitor for a mutation and alteration in a gene, that we can do harm if we don't actually understand the biology. And then finally, just wanted to thank everyone in my lab, but also one of the joys of doing what we do is working collaboratively with people across the world. And it's really exciting to think about what everyone is going to hopefully achieve together for these children. So thank you again. And I'm happy to take any questions if you have any.
Thank you very much for an excellent talk. I'm looking in the chat. I see some thank yous, but I don't see a question. So let me start off with a couple of comments. As I said, this is an excellent talk. To get to the basics here, so what you've shown the group here is that we can analyze tumors, looking at the tumor tissue, leaving aside the cell-free DNA question for a moment, with a variety of technologies now. There's next generation sequencing, which is a generic term that now encompasses a lot of different approaches. And one can do targeted next generation sequencing where you know specific genes you want to look for, or there's whole genome sequencing, which is a different enterprise entirely. And there are different approaches to this. There are different costs to this. And so we're looking at various ways of getting that done. There's also the issue of chromosomal aberrations that are at a chromosomal level rather than at a specific gene level. And those are detected by different technologies, as you've shown. And so our clinical colleagues and others across the world need to know that as we're looking at these, there are multiple ways of classifying that are complementary rather than I'm going to do this one or I'm going to do that one. I think there's a lot of impression of let's just do NGS, and that doesn't work, as you pointed out, very effectively. It doesn't work in all of oncology very well, but it certainly works even less well in neuro-oncology and pediatric neuro-oncology. And then finally, there's the methylation array issue, which will be coming up shortly from Dr. Aldapi, and which we still don't quite know how much trust to put in that, to be honest. So there's a single database which is constantly being added to. But the questions that I have, and you can direct your attention to this, is Ken will also, obviously, but what is the gold standard for diagnosis? When you have a cluster, what do you call that cluster other than just saying it clusters? Where are the gold standards? Can we take a tumor that somebody called pilocytic astrocytoma and say, no, it clusters with gangliogliomas or whatever? Go ahead.
Yeah, I mean, that's an excellent question. And I think as a community, we really need to understand these nuances, because the reason I say it is, sorry, I think someone else is, let me just, is I think there's a danger in, as you said, saying, and we see this in clinic already, where we get a patient come in and they say the tumor has been profiled and there's nothing identifiable. But unless you actually understand how the tumor has been profiled and understand the nuances, you can't interpret that. So my feeling is that it's not one thing. The histopathology is never going to be made redundant by genomics, right? Pathology and what the tumor looks like is a really important part of the diagnosis. And then whether it's a mutation or a copy number profile or a methylation, these are just different ways to look at the fingerprint, and you're looking at that fingerprint of that tumor from different angles, right? One is either with DNA and mutation, one is by methylation. And so, to me, the gold standard is an integrated diagnosis that combines the histopathological interpretation, looks at the mutational profiles and the copy number profiles, and looks at the methylation classifier and says, when I look at these three different metrics, this tumor is most consistent with whatever. Because as you said, the methylation classifier will just tell you what tumor that tumor is the most close to and closest to. It doesn't tell you anything about whether it's a BRef V600E mutation or a higher rearrangement. It just tells you what that methylation profile most closely resembles. So in my opinion, a methylation profile by itself is not sufficient. I think you need that mutation call. I think you need the copy number calls, which you can get from methylation or copy number. I think in pediatric brain tumors, where we're frequently seeing single structural variants and rearrangements, that often you need an RNA-based fusion caller to complement it. So there are nuances, and these sorts of interpretations and diagnoses, in my opinion, need to be done in centers that are looking at childhood brain tumors all the time.
Thank you. As a neuropathologist, it's nice to know I'm still going to have a job for a while.
Oh, you have the most important job.
Can I ask a question, Dr. Miller?
Of course, please.
Thank you. If you have covered it, I apologize. But, when we do pathological biopsies in a tumor, sometimes, depending where you are taking the biopsy, you might get a different answer. And in the same thing with these molecular pathology diagnosis, are you going to get a uniclonal tumors, or are you going to have tumors with different clones, and are they going to affect how you are able to apply when it comes to treatment?
You want me to take that, Dr. Miller?
Sure, yes.
We have looked at that as have others, right? So it's a really good question, and I think the answer is we need to look at it more. But the basic drivers that we are studying, right, the BRef mutations or the histone mutations, they tend to be clonal, and therefore present at all of the different parts of the tumors. When we have, in the small number of tumors that we've looked at with the multi-regional, the drivers tend to be clonal. What I think is an unanswered question is metastases, right? Primary and METs, and how similar or different they are. I suspect there'll be a clonal trunk. The trunkal mutations will be similar, but whether there are sub-regions that have additional subclonal mutations possible, I don't think we've, as a community, looked at enough tumors. And then the other big thing from a surgical perspective that we talk about a lot is the role of rebiopsying on progression, right? We have a tendency not wanting to put our children through multiple craniotomies, but particularly as we start using these targeted inhibitors, understanding the evolution and whether the tumors are acquiring resistance drivers is something that we're going to need to understand.
Thanks. Thank you.
To add to that, we don't know a whole lot about pediatric tumors because they're less common and they're less well studied, consequently, in this manner. But we do know that for adult gliomas, there's regional heterogeneity. So there are trunk driver mutations that are the main clone that starts the tumor. But then in different regions, you can have subclones that have additional mutations that are different from other regions. And that does complicate the therapeutic process with recurrences. The other thing we haven't gotten into at all here, because it's become less fashionable to talk about it, although it hasn't gone away, is the stem cell theory of cancer as applied to these tumors. And the fact that after you even had a gross total resection, is there a reservoir in a niche somewhere of stem cell-like cells, whether they are originally stem cells or otherwise, that have acquired stem cell-like properties that can then repopulate the tumor And these are the cells that are commonly thought to be the resistant cells to therapy. Any comments on that?
Yeah, it is. We're definitely thinking about it a lot more in pediatrics. With the for two reasons. One is the understanding or the increasing understanding that a lot of the mutations that we see are locking the tumors into a more undifferentiated state, right? For example, the histone mutations are locking the cells into a more of a OPC-like primitive state. And then definitely for resistance, I can talk to what my lab's doing. We are studying resistance mechanisms to a number of different drugs, and we definitely see, in addition to genetic mutations causing resistance, that changes in cell state can also, right? The cells will become either a little bit more differentiated, often a little bit more differentiated, depending on the drug, to persist the drug that's been given, and then that can then also cause like tumor growth. So yeah, that is very understudied in pediatrics.
And one last point about that is that the things that are done to treat tumors also cause genetic alterations. There's particularly radiation. Again, looking at an adult model, David Lewis showed years ago that if you looked at IDH1 mutant gliomas in adults that then recurred after radiation and temozolomide, that they had gone from a status where they were not microsatellite unstable to ones that had microsatellite instability and had mismatch repair. And it started to acquire all sorts of new mutations because of that new status. And it was a change from the original tumor. So yes, rebiopsy is important because there will be genetic changes that are therapy induced. Okay.
Dr. Miller, can I just ask one quick question, if I may? Pediatric tumors is not that many to start off with compared to adult tumors. And now that we had the histological classification, that makes subgroups smaller, but now we have got so many genetic aspects to look at. How do we then have enough tumors to do studies if there are so many heterogeneity? Any thoughts, Dr. Miller as well as Dr. Bandopadhayay? Yeah.
Cancer is obviously collaboration in large consortia. So in North America, we have the Children's Oncology Group. In Europe, there's an equivalent group. It's SIOP. And we are now, of course, extending these international collaborations. So COG includes a bunch of Australian institutions. I think it's important that we pool data, we pool specimens in common laboratories that do these kinds of investigations, because otherwise single institutions will never come to answers on these very rare tumors. You're right.
Thank you.
A question in the chat, which is, what is the bottom line message here? And we're going to run short on time, but I think the bottom line message is that the landscape has changed. We no longer just take something out, look at the pathology, give a diagnosis, and have a cookbook treatment. And so treatments will become more and more personalized as the pharmaceutical industry develops targeted therapies for the particular identified genetic alterations that are there. And so that's the lesson. We're not there yet very much, but we're getting there.
Yeah. And I'll just add to that message, because for me, this has been a big lesson, is that BRef is understanding the biology, right? Just saying that there's a mutation in the gene, therefore the inhibitor will work, it is dangerous, right? So you absolutely need to understand the biology and the nuances of the inhibitors that are being used before we can just use them.
I think just a small mention that Mr. Salindra was wondering what's the bottom line for countries with developing countries where they can't afford these all these genetic tests. I suppose here the maximum resection, and then able to see what can be afforded. Any comments on that, Dr. Miller, Dr.
Well, there are two aspects to this, Naren, that I think are relevant. One is availability, and that in terms of geography is now really not an issue very much. There's FedEx, And most of this stuff can be done in paraffin and fixed tissues, fixed and paraffin embedded tissues. So if you have the resources to send it to somebody who can do it, whether it's here in the States or in the United Kingdom or in Germany or wherever, then I think that's something that can be done. The question, though, is the other question is cost. These are not cheap tests. For us here to send an adult glioma out for both the chromosomal array and NGS testing is in the vicinity of $6,000 at least, that somebody's going to pay. There are companies like Foundation One or Caris who are right now doing this at almost no cost to patients because either Medicare or the insurance companies will cover this for adults. But for pediatric tumors, that kind of coverage is less available. And then in the international setting for countries that don't have it in-house, those costs can be prohibitive. So I think the international community may have a responsibility, just as they've talked about the responsibility for getting vaccines for COVID out to places that don't have them otherwise, that we need to find ways to do this for our pediatric patients across the world.
Thank you.